Good evening, delegates and participants. Thank you for joining Shield Connect. And today we are back with Dr. Ritu Mem's program. She has organized this mixed bag webinar. So we have today total 5 icons on this platform. So let me first introduce our organizer and speaker, Dr. Ritu Santwani ma'am. Ma'am is obstetrician and gynecologist, IVF specialist, and founder and CEO of 360-degree Healthcare Studio and consultant at Inamdar Multi-Speciality Hospital in Pune. Ma'am is co-founder of MAAM and board member of SWWC. And now let me also introduce.
Nishant, wait.
Okay,
Let
ma'am.
me welcome everyone. Then you introduce, madam. Stop sharing the screen. Yeah. So, knowledge sharing is the new mantra in this digital era. A warm welcome to all of my dear friends who have joined all across the geography. I'm able to see that some of the delegates have joined here via Zoom link and mostly are on the YouTube. So, friends, on the great request, today we are going with another series of the mixed bag webinar. And today we are having the stalwarts from all across the India. And I am very much thankful to my dearest Tarni madam for accepting the invitation as the chief guest, dear Dr. Komal as the guest of honor, and our 3 stalwart speakers, Dr. Mandakini madam, Dr. Anita madam, and Dr. Shushila madam. So first, Dr. Nishant is going to introduce the Tarni madam. Then I will welcome her. Friends, we are not going to waste much time. Don't worry. As always, the program will go on time. Yeah. So Nishant, please introduce madam.
Yes, ma'am.
Yeah.
Sure, ma'am. Yeah. So let me welcome Dr. Tarini Taneja, ma'am. Ma'am is a chairperson. Ma'am is a chairperson at Delhi ISR and chairperson Breast Committee of FOXY 2013 to 15, international member of FIGO Working Group of Breast Disease, executive member of DMA, vice chairperson of DMA Women Wing, RCOG associate member, board member of Journal of Obstetric Gynecology Research and Practice, president of NGO of Manzile Rahat for Women Empowerment. Ma'am have various publications and also received various awards. So let me welcome Dr. Tarini Taneja, ma'am.
Yeah. Tarni madam, a very warm welcome. Stop sharing screen. Warm welcome, Tarni madam. We all know Tarni madam is very busy, and thank you, madam, for accepting the invitation and gracing this occasion. Madam, we need some blessings from you. Madam, some doctors are saying hello to you, especially the Dr. Frigra has joined from the Romania. She's saying hello.
Oh my God. Thank you. Thank you, Dr. Ritu. And I'm really thrilled to be here at this prestigious platform of 360-degree healthcare, women healthcare. That is running by my dear friend, Dr. Ritu Santwani. She is the founder and CEO of this 360-degree healthcare studio. Dr. Ritu, we just heard about her introduction. She has the highest degree in OBGYN. She's MBBS MS, and she is
Ma'am, you are the chief guest, not me. You are the chief guest.
No, little bit. I have to speak about you. And I just remember one quote of Mahatma Gandhi, like live as we are just going to die tomorrow, and learn as we are going to live forever. So Dr. Ritu is doing the same thing. She is learning every day, updating herself, and making learn and update and exchange the knowledge for others, doctor. So I'm really happy, and she's so consistent. I think for the last 3-4 years, she's doing continuously before the COVID era. And this COVID also made us learn that is this blessing in disguise. We are expert now in the webinar online, this learning courses. And one word about Ritu I would like to say. Her action speaks louder than her words. She does too much. She's always busy in learning and making and giving education, disseminating knowledge to the others. And today's webinar is very important. It's the mixed bag, and very stalwart and master in their field are speaking their topic, that is the increasing rate of the cesarean section, hypothyroidism and infertility, and vaccination in pregnancy. So over to Dr. Ritu Santwani, the organizer of this show. That's a very, very popular, not only in the India, but it's internationally. So all the best to all the delegates who are connected. I believe they will all literally will be enriched by the knowledge. That is a very practical subject, that is cesarean and hypothyroidism and vaccination. So over to Dr. Ritu.
Thank you.
And
Thank you.
thank you so much, dear, for giving this opportunity to me to share the
Madam, pleasure is
platform.
mine. Pleasure is mine, ma'am. Thank you. Thank you so much, ma'am. Ma'am, here I want to add, because in the Corona time period, I have got the friends from all across the geography. I am not limited to India only.
That's I'm saying
I can say
internationally.
that is only because all our knowledge, all are having a craving for the knowledge. So now we are having a group in which we are having the doctors from all across the globe, which we all share our communication. Yeah, Nishant, please introduce Komal madam, our guest of honor.
Yes. So today our guest of honor is Dr. Komal Chavan, ma'am. And ma'am is a chairperson of Foxy Medical Disorders in Pregnancy Committee 2019-22. Ma'am is also medical director of Chavan Maternity and Nursing Home, senior consultant, DNB teacher, and unit chief of VM Desai Hospital in Mumbai, ex-honorary professor of Dr. R.N. Cooper Hospital in HBT Medical College. Ma'am is also zonal coordinator for Foxy President 2022-2023, chairperson of AMOX Family Welfare and MTP Committee since 22 to 24. Member and managing council of MOX, joint secretary of ISOBAP Mumbai chapter, scientific secretary of EFG, national expert for Foxy UNICEF Lakshya project, national trainer for Foxy Dira and RAC project, convener for Foxy Guinness World Record 2021 break free from anemia. Ma'am has also received various prizes and awards and have lots of journals and review articles. So I welcome Dr. Komal ma'am on this platform, and I hand over the session to ma'am. Thank you so much.
Yeah. A very, very warm welcome, my dear friend, Dr. Komal. I know Dr. Komal is also very, very busy in her election campaign. Also, I'm really thankful to all of the starbirds that all have accepted the invitation and taken out their time. So a very, very warm welcome, dear Dr. Komal. We want some few words from you.
Thank you. Thank you so much, Ritu. And I think when Ritu does it, she does it with a lot of dedication and a lot of finesse. And it is the invitation from Ritu is always so overwhelming. And it is a pleasure to be part of this program. And we are all here for knowledge. And we know knowledge empowers us. We are talking about knowledge. And I think Anita ji will really agree with me. Like knowledge is like a garden. And if it is not cultivated, it cannot be harvested. So we really need to talk, not every bit we are doing, we are having so many webinars and everything, we are sharing knowledge. And it is a very nice to see that not only the people from India, but there are so many people who are joined from all over for the program. So it is a lovely platform where the knowledge sharing is happening at the real large level. And the topics which you have chosen today for this mixed bag episode, that is rising rate of cesarean section, vaccination, thyroid, they are so practical topics. You will have these queries, everybody will have problems related to these subjects. So they are very the much sort of topics, and a very good scientific treat what you have planned for everybody. And I'm really honored to be there. Dr. Tarini, I know her since so many years. I think Ritu and Tarini from years, I think many, many years. If I go back, then I feel, oh, I have become so old. Like 20 years we know each other in Foxy, going around. So I think long back when Tarini was the chairperson, even before that. So we know each other, and that is the joy that we always feel good to be connected with each other. And it's not only the knowledge, but the interactions what we are having on this platform, they are really amazing. So I am really happy to see Dr. Mandakini Meg, Dr. Sushila Gupta, Dr. Anita Sabharwal, dear friend, all here who are going to talk on the subjects, eagerly looking forward for all the topic discussion. Thank you so much, Ritu. and let us start the academics. I'm really waiting.
Yeah. Thank you so much, dear Dr. Komal, for joining. Now, without wasting time, we are taking the first speaker. Sorry, friends, I'm getting a lot of the messages. Ma'am, 15 minutes is passed in the introduction only. So, yeah, a very, very warm welcome to Mandakini Meg Madam. Yeah, the first speaker. Yeah, Nishant, please introduce the madam, then I will welcome.
So, ma'am is the chairperson of ICOG Foxy 2020-21, International Vice President of MWI Central Asia, Vice President of AMWI Central Council, National Vice President of Foxy 2012 to 2013, past President of Indian Federation of Ultrasound in Medicine and Biology, past Dean of Indian College of Medical Ultrasound, Chairperson of Imaging Science Committee, the Director of Health Service of GOM, in charge of Family Welfare, and Advisor to Officer on Special Duty, Family Welfare, Health Department, Mantralaya, Mumbai. Ma'am it's also prestigious post of a superintendent camp of Kama and Alplace Hospital for Women and Children in Mumbai from 91 to 95, and maternal health consultant for Government of Maharashtra UNICEF. Ma'am is awarded with Dr. D.K. Datta Best Publication Award for 2 books on recent advances in postpartum care and playing by the rules. Published books on PET, prevention, examination, and treatment of domestic violence and sexual assault cases. Dr. Ganantra Award of MOPS for community service in OBGYN, and received many more awards from different associations. So I welcome Dr. Mandakini ma'am for the first session. Thank you, ma'am.
Yeah, here.
Warm welcome, madam. Warm welcome. So, madam is on, I think, is speaking with someone. So, meanwhile, please introduce our next speaker, Dr. Anita, madam. Nishant?
Yes, ma'am.
Nishant.
So, our second speaker is Dr. Anita Sabharwal, ma'am. Ma'am is going to take the topic vaccination in pregnancy. Ma'am is a Foxy champion for Wonder Foxian and Foxy Superstar recipient of Foxy Dhira Award. Ma'am is president of a Forum of Obstetrician and Gynecologists of South Delhi, chairperson Public Awareness Committee of ISCCP 2019 to 21, past chairperson of Adolescent Health Committee, awarded a gold medal in AOGD, executive member of AOGD from 2017, 19 and 20, executive of NARCHI Delhi, invited member of Women's Cell of Violence Against Women, WAM Cell of Foxy, advisor at MTP Committee of Foxy, master trainer of Core Group Dhira by Foxy, certified UNICEF GBV trainer, member of Safe Motherhood Committee Foxy, national faculty with IMA and GOI 2006, North Zone coordinator of PSC Foxy, and organized more than 500 updating programs, conferences, CMEs, and numerous preventive health camps, community talks, public health awareness talks, including cervical cancer awareness and prevention, and various walkathons, and executive of AOGD Outreach Committee. So I welcome Dr. Anita Sabharwal, ma'am, also on this platform. Thank you, ma'am.
Warm welcome, Anita madam. Warm welcome. Really thankful to Anita madam that she has accepted the invitation. Madam is going to discuss with us a very, very important topic regarding the vaccination in pregnancy. There is a message from Mandakini. Madam, she is not able to unmute herself. Sahiti, please check. So friends, Anita madam has also a lot of achievements in her profile. Madam, a very, very warm welcome. A warm welcome. Yeah, please introduce Sushila madam.
Sure, ma'am.
Nishant? Yeah.
Yes, ma'am. So the third topic will be covered by Dr. Sushila Gupta, ma'am, that is hypothyroidism and infertility. So ma'am is a director and senior consultant obstetrician and gynecologist of GNH Excel Medical Center in Shalimar Bagh, New Delhi since 1986. Ma'am is also consultant at Fortis Shalimar Bagh, member of Press Committee Foxy, advisor of DGF North since 2018, chairperson of Breast and Cervical Cancer Awareness Screening and Prevention Committee 2018 to 2020, president of Delhi Gynec Forum North 2016 to 2018, chairperson of Reproductive Endocrinology Committee AOGD from 2015 to 2017, chairperson of Adolescent Committee of AOGD 2013 to 2015, and ma'am has also received many awards like Swasthya Ratna Award, Delhi Medical Association recently in 2022, Women Health Icon Award in 21, Distinguished Medical Luminary Award by IMA Delhi in 21, Women Achiever Awards, recipient of APJ Abdul Kalam Excellence Award and recipient of DGF Award for Excellence in Gynecology in 2014. So I also welcome Dr. Sushila Gupta ma'am on this platform, and I hand over this session to Dr. Ritu.
Yeah.
Thank you.
Warm welcome, Sushila madam. And I'm really thankful to Sushila madam also that though that is a very vast topic, the thyroid and infertility. I तो always call her Sushila di. I never call her Sushila madam. So for मेरे लिए बड़ा मुश्किल हो रहा है madam word use करना उनके लिए. So please, Saiti, please check. Mandakini madam is having some problem in joining. So
yes, ma'am. Yes, ma'am.
Yeah.
I'm checking.
Yeah, a very, very warm welcome to you. I know the topic is very vast, and to summarize that topic in 12 to 15 minutes is really very, very difficult. So till the Mandakini madam is joining, Nishant, you please call them madam. She is having some difficulty in joining.
Yes, ma'am. Sure.
So, yeah. Before we switch to our first session, I again want to welcome my all dear delegate friends who have also joined. I'm able to see so many friends. Yeah, hi, Dr. Rashmi, Dr. Kalindi. So many friends have joined, Dr. Kalpana, Dr. Geeta, Dr. Madhu, Dr. Uma from Tamil Nadu, Dr. Ritu Sabarwalia. So many friends have joined. A very, very warm welcome to all of you. Before we switch over to the first academic session, मैं भूल ना जाऊं, a very, very warm welcome to all our dear friends and delegates with this roses. Tarni madam,
Wow.
Mandakini
Lovely,
madam, Dr.
dear
Komal, Shushila,
That's so
Shushila
lovely.
di,
It's
and
lovely,
Anita
yeah.
madam.
That's
You are
so
looking
lovely.
like this.
Beautiful.
Ritu.
It's the
You
color
are looking like
combination
this.
is so good.
combined.
Yes.
Yeah.
Right. Thank you.
It's so lovely.
Thank you.
Ritu, you are looking like this
Mandakini madam,
strawberry.
Yes, Mandakini ma'am has joined.
Yes.
Yes.
No, I'm here only. Yeah.
Dr.
Ritu, very nice,
Mandakini.
sir. You are
Dr.
like
Mandakini,
looking like a rose.
please.
Your background is like a rose,
Thank
and
you.
you're glowing and yeah, you know, blooming and glowing. Yeah, so
Thank
good.
Mandakini.
Thank you.
Dr.
Yeah.
Mandakini.
So, should I start?
Yes, madam.
Yeah.
Yes, madam.
So-
Yes, madam.
So I think, thank you very much, Ritu. I'm very excited to be here, and I'm looking from the far places that you are doing. Ritu, when are you going to invite me to this very, academic platform as well as a very, very exciting subjects? Even the choice of speaker is so good. So I think I'm really honored, Ritu, to be here along with my friend, a very dear friend, Anita. All your morning greenery makes me so happy. So thank you. And third friend, मैं नाम भूल गई जरा उनका नाम बता दीजिए. What is the
Sushila
name
madam.
of madam? Third madam. Sushila madam. So
Yeah.
very, very happy. My beautiful both the chairpersons. Tarini madam. I can call her.
Hello,
today,
Dr.
madam.
Mandakini. Waiting to
hi.
listen you. Waiting to listen you.
Tarini and Komal, dear, my colleague from Mumbai, and we were together till now. I was telling Ritu that we just coming from our Foxy office. And all the viewers here, very good evening to all of you. And I won't waste much of the time because the topic itself is please mark the time, Ritu, because
Yes.
and recently we held this optimizing labor, CME very well attended. Me and Komal were there, and this rising rate of cesarean section in every part of the Mumbai, they want to listen to it. It has become such a hot topic, and I think all of you must have seen a video, viral video. I think on our Foxy, WhatsApp groups that million cuts, it is calling the million cuts. So it's a very horrible state of affairs and depicting the doctor in a very bad light. So I think it is a proper time to discuss the rising rate of cesarean section. And recently we, on the 11th April, we celebrated the Safe Motherhood Day. I want to quote our President Figo 1997, which is so true today also. That is, women are not dying because of a disease we cannot treat, but they are dying because societies have yet to make the decision that their life was worth saving. So it's so important. All our world leaders like Dr. C.N. Purandare, Dr. Arul Kumaran, we were very lucky to be with him for today's lunch, hosted by our dear Niranjan and Komal. So thank you for that honor also. So I think first of all, we all deserve the congratulations to all of you, because we have really done some good efforts. The efforts were on the part of government and on part of Foxy and all the practicing obstetrician, because maternal mortality ratio was brought from say 400, 500 to 103 because of our consistent efforts, because of our wholehearted support to so many schemes of various prime minister, whether it is Manmohan Singh, whether it is anybody from last 40 years, consistent efforts of the prime ministers and the government. We are supporting them. Now we are having Pradhan Mantri Surakshit Matritva and so many forums. But our association with this is very big, and we all deserve a big congratulations to bring down the maternal mortality rate. Now the cesarean sections is increasing. The optimal cesarean sections rate is unknown, but it varies between the facilities because of the differences in the obstetric population. And I will go one step further, because me, Komal, we have all worked in the referral hospital. I used to do alternate day or every third day, one rupture uterus I used to operate. So we have a series of rupture uterus, series of ruptured ectopic, series of complications, BPH. So it depends on the actually institute to institute, whether it is a referral institute, it is a purely private institute, or it is a just solo maternity hospital. You can see here the rate, this thing that the cesarean section rates are very high, because we know that in Telangana, cesarean section, the other day I was in Hyderabad and Dr. Shantakumari said that to our FIGO president, sir, Telangana rates were so high that is almost 90%. Can you imagine? That is WHO 15% to 20%, but Telangana is having the 90% of the cesarean section rate, and no wonder it is popping out the government authorities and so many humanitarian authorities. How come the cesarean section rate has increased so much? And also the Lancet series on the cesarean section rates, that is how to stop the cesarean. There are a variety of articles in the Lancet that how to stop the cesarean section increase rate. WHO has estimated that around 6.2 million excess and not medically indicated. WHO itself is saying that it is not medically indicated, and the Brazil and the China takes the lead. So what is the FIGO position? How to stop the cesarean section epidemic? That is 2018 in USA, China, African countries. All these has got the increased rate. Instrumental vaginal delivery. There are many causes that we have stopped, doing instrumental vaginal delivery, delay in doing the procedure, inadequate facilities, skills, etc. Hospital-acquired sepsis with a resistant organism. All these things are leading to increased cesarean section. Here, I just want to see the, you can see the case, two previous LSCS with the live birth 0 and hysterectomy was done, and that is internal iliac, and 14 plus these transfusions were given. It was a maternal near miss and ventilator in the why? Because the increased this placenta accreta syndrome, and because of the rising rate of the cesarean section, the placenta accreta incidences have very markedly increased. You can see here that from 3% to it has come to 67% of the cases, because the rate of cesarean section has increased, and that is how the adherent placenta is there. So we always think that the once a cesarean section, always a cesarean section. A scar is a the scar on a scar begets a scar. So more vaginal birth and the reduce the rate of cesarean section is the need of the hour. So what does WHO recommend? WHO recommend the optimum cesarean section is 10 to 15, but it was in 1985. Since then, you can see even the indications have increased. Indication is differentiated and incidences is changed. So section rate is higher than around 10% of the population level are not associated with decrease in the maternal mortality and neonatal mortality. So why the trend has gone up? Why cesarean sections we are doing more? So there are few causes. I'm going to read very important causes only, because it is technically relatively simple for primary sections or in primaries. Then the trial of labor after the cesarean section is not easy. So all cesarean become the indication for the repeat cesarean section. Then planned anesthesia, pediatricians, muhurtam deliveries. The other day there is a panchang, whole lot of panchang, and the pandit is there. 8:05, 10:03, that kind of muhurts are giving for the cesarean delivery. And emergencies, cesarean has the higher risk and the litigation. Then non-availability of anesthetic 24/7. That is how the obstetrician want to plan it in advance and do it in a proper time, so that the every facilities is available at the time of cesarean section. Also, very important, the non-medical causes may be a risk of litigation, violence. If they loses the patient, then the violence is so much nowadays, it is so increased. Lack of public awareness, they do not know there are so many causes, and patient may succumb to the any time in the surgical or in the PPS, etc. Labor is painful, they cannot tolerate and the Bhaskar other day was saying they are too posh to push. So that is another story. Short time for the surgery, then the labor, because within half an hour or 1 hour you are just out and you need not supervise the labor. To avoid the late labor decisions, suppose in the middle of the night now she's not progressing, then you are taking her for the cesarean section. And many, both doctors and patients are not aware about the short-term and long-term better maternal and fetus outcomes. So these are the few of the very important causes of the increase. Now the feedback, what feedback we have got from the district, especially from the Telangana, that common indications are on demand, presumed fetal distress and post-cesarean pregnancy, and the this trial of labor, difficulties in giving the trial, social pressure, poor maternal efforts. All these things are, causing the cesarean section rates are high. Common and important indications, which we all know: fetal, prolonged labor, breech presentation, vaginal deliveries, multiple gestation, previous cesarean section. On maternal request, it is a definite no. It should not be on demand. And cesarean section on demand is definitely no. Now, what are the factors which has increased? So, there is a, demographic changes in the population. Small family, they want to have only one child, or, just small family now. Advanced maternal age, then multiple pregnancy, obesity, obstetrician decision, there is a time pressure, fear of litigation, etc. So all these things are very, very important. And increased use of intrapartum. Suppose we are continuously monitoring and suddenly there is improper, inadequate, fetal rate, pre-eclampsia, medical disorders. In those conditions, we ourselves want to actually do the cesarean section, elective cesarean section we plan. So more sections, a definite no. Cesarean section on demand, a definite no. Maternal requests are done for the social convenience, planning, peer pressure, tocophobia, fear of labor, to avoid the fetal risk and to avoid the maternal. So tocophobia, maybe, so many people are listening to the horror stories, surgical backgrounds, fear of pain, etc. So of course, if you are in the higher center, then you can go for the, this epidural anesthesia, but the facilities are not available at all the places. So what are the solutions? Solutions are incentive and equal remuneration. It is a point of debate. And I think we are debating at every forum that the charges for the vaginal deliveries in the cesarean section should be same. So that it should not look that we are doing for the monetary benefit. And doctors should not have the flock of going for the monetary benefits. And that is how, I can tell you one story in Maharashtra from some primary district hospital, taluka level. One doctor has done some 10 or 11 cesarean section in a day. and the doctor was suspended. And she was a government doctor. It was not a private, it was a government. And they have suspended the doctor. It was a story, or a big story. So I think they are being monitored not from the private point of view, but from the government point of view also. So all these are the possible solutions. And most important solution is to, deliver the patient normally. And a second thing, what I want to say here is that the instrumental delivery has to be practiced. And also the, antenatal exercises, birth attendant, all these things are very helpful in conducting the vaginal deliveries. Now, the increased rate of cesarean section does not mean that there is a reduced neonatal mortality and improved maternal mortality. On the contrary, I can say it is more. So, because the cesarean section is a more morbid condition, and it doesn't mean that it is solving all your problems. So what we proceed? We proceed with the intervention targeted at women. Like women should be aware, health education should be there, essential component of the antenatal care like nutrition, lack of obesity, improved anemia, and also the exercises, and so many things are there which should be Then safety also, today we have to sit a round table and discuss the route of birth and target to reduce the cesarean section. Then healthcare professional also, that the implementation of evidence-based clinical practice guidelines combined with the structure mandatory second opinion. That has come out of the discussion that we must have a second opinion for the cesarean section like we do in the MTP. Say 20 weeks and beyond we do in the MTP. So that has also come out of the discussion of at various forums that second opinion has to be taken whether she really needs a cesarean section. Then the focus on the vaginal birth, there should be a balance for non-clinical, clinical factors contributing. There should be a balance. And we are the best judge when we are with the patient. We are the best judge that how we are trying to conduct the delivery but unable to do, and there is a definite indication for the cesarean section. So we have to balance the risk and benefits. We have to also see that we have to prevent the primary section. If you prevent the primary section, then most of the problems will solve. The most important aspect is to encourage the vaginal deliveries, and you can see there is a great change in the cesarean section indication. Previously it was obstructed labor, etc. Now it is a indication is around 24%. The previous cesarean section has become the indication. Then there should be proper intrapartum care. There should be facilities available so that whenever there is any fetal heart deceleration or so, that you can take the patient for the cesarean section. So these are the tools: simplified photogram, then then all our monitoring, prolonged second latent stage they would describe in detail, which I'm not going to tell here, but then these are all the things which are recommended for the promoting the vaginal deliveries. At least 2 hours of pushing in multiparous or at least 3 hours of pushing in nulliparous is done. Then later on you can decide for the cesarean section. Similarly for the fetal heart dressing also, they have given the indication. Then we have to routine use of practice during the labor and childbirth are to be monitored for unnecessary, unwarranted, all these things. I think repetition. Most important thing is now the birth companion. So you can see the result. When there is a birth companion, she feels so comfortable. She can ask for the water, she can ask for she feels very homely, and otherwise she is all laid down in a unknown circumstances. So prolonged labor is reduced by 95%. Episiotomy 44%, cesarean section 20% if the birth attendant is there. Prolonged hospital stay by 39%. Admission for newborn 13%. You can see everything is reduced if there is a birth companion and the attendant with the patient. So I think it is a great thing to introduce the birth companion at all levels, whether it's a government hospital or private hospital, so that it becomes very comfortable for patients to deliver normally. And the second thing is very important. We have lost the art of women deliveries by instrument delivery, and very rarely now the juniors are practicing this. So we should, as a professors, we have many professors here, we should practice the vacuum forceps, and regularly they should be taught to conduct the instrumental delivery. Also the group practice also, it is possible in Mumbai or big metros. And also 60 to 8% is the trial of labor after the cesarean section. There are many causes like macrosomia, then the deflex head, close monitoring has to be done. Prevention of the maternal obesity to reduce the cesarean section. And then the intervention to target at health organization. Sole purpose of the reducing rate of cesarean section is collaborative midwifery, and is recommended only in the context of. So now the midwives or the ANM or the nurses are being encouraged to do the normal deliveries, and it has become a very big component between the consultant and the patient. There is a nursing services has become very important. All the friends who are in the UK, you can see there, whenever I entered in the ward, there were nursing station. Doctors were rarely coming. They were taking all the decisions. And when there is a need for the intervention or any kind of operative, then the doctors are called. So I think nurses are going to play a major role. And also economical balance for the work done. Intervention targeted for the health professional, already said. Audit, self-audit is very important. Every institute do the self-audit for the obstetrician, anesthetists, what we did, how many rates are there. They should publish the rate of cesarean section in their own hospital. Very important. So we have to analyze. And for the Robinson's classification, every woman, there are many criteria which we, this modified Robinson, and I had a privilege of meeting him at Hyderabad. So wonderfully done. I have learned, listened to all his workshop, and there are Robinson for the multipara, primary, all the groups are given, and they are all included into 10 Robinson criteria. So WHO guidelines are there. Mandatory, they have made mandatory second opinion for the cesarean indications, and audit and feedback. And hospitals should oblige to publish the annual cesarean section rate. Hospitals should uniform classification for the cesarean sections. Women should be informed properly on the benefits of cesarean or normal delivery. Financing of the hospital should be partly based on the cesarean section. And the feedback was taken from the patients. They have given different type of stories. Their experience LSCS would have been done more appropriate. I felt like I was on butchers. Sometimes patient also want cesarean and they don't want to undergo the normal labor. So there are various kind of feedback. And my last slide, that now the friends, the onus is not only on us as a obstetrician, but it is on the public. We should not take all the responsibility. We alone are not responsible for increasing cesarean section. Public, the paramedicals, policymakers, healthcare professionals, they have to be made aware, committed, and self-audit. Safety of the doctors is very, very important, and balance is the key. So we have to take home messages that every effort should be made to provide cesarean section in women who are in need, rather than striving to achieve a specific rate. We should not go for the rate, 15, 20, and we have to look after the patient and the mother. So we should not target the targets, but we have to see the well-being of the mother and child, and we should not try to achieve a specific rate. Make it a safe surgical procedure, and let her enjoy the joys of the motherhood. And last but not the least, friends, I am contesting for the post of President Foxy. With all your support, blessing, guidance, and love, I think you please give it to me, and the voting will start from the 1st August to 10th August. So thank you very much for the patient listening, and thank you, Ritu, for having me on this wonderful platform. Thank you very much.
Thank you so much, madam, for such a brighter lecture. You have covered all the points in that. So friends, if there are any queries, please write in the chat box. So madam, before you leave, I want, because this program is attended from the young budding gynecologist and up to the senior gynecologist. I want you please share some tips how to be successful.
nahi, how to be successful in practice.
In practice and in life.
I think there is only two words. One is a sincerity, and third is a skill development. So I just want to share one of my experiences. I was very young at that time when I started my career. Of course, we all are young, and I was so excited to do my first cesarean section. And I did not know what is in the store for me. And that time we were doing all cesarean section in the local anesthesia. Please mind it. Local is, you require a lot of skill. But still I said, okay. And then I went to the labor room and, things like that. And they say, oh, she's not progressing. I was just raw. I said, no problem. We have to take her in the OT. We took her in the OT. And the experienced person was assisting me. And all experience, I was the new. And I said, local I have given, I have taken the incision. And she started pushing. And the intestine started coming because it's local. So my experienced obstetrician told me, madam, please wait. I was at 25, I was madam, because I was senior. I said, madam, please wait. They stopped it. And then they took out the legs on the up and the patient delivered from below. That was a lesson I learned, very hard lesson. And I was shocked. How can we go, madam, patient progresses like this is third gravida. Okay. I said, no problem. I said, I'm ready for any punishment. In the meantime, my boss, Dr. Rajwade was there. She came inside and she told me, Mandakini, and she saw me, ligating the tube. So she thought I'm such an expert surgeon. I sutured this uterus also. Now I'm at the ligation. She said, Mandakini, how come you can do ligation so fast? Then I told her, madam, baby niche se nikal gaya, but I'm doing the ligation. That was my first section. And I just wanted to share this story. After that, I concentrated, focused on developing the skills. Even I could do anesthesia because that time anesthetists were also not there, many of them. So my version of motivation or inspiration to my all juniors is now they are at very, very high things. We get all the facilities. You are not in that era. So now first is you develop respect to a teacher. And guru ki bahut zarurat hoti. Without guru, you cannot do. And third is a very sincere efforts. That is my, and fifth, which is for today's generation, is protect yourself. If you protect yourself, you can protect all your colleagues. That is my, message to all the young people. And
Thank you, madam. Thank you so much. Friends, with us, the another stalwart, Tarni madam, is also with us. Tarni madam, please share some tips how to handle the centers in the different cities. Madam is having a center in the Muzaffarnagar also and in the Delhi also. So there are a lot of budding gynecologists are joining. So share some tips how to handle that, because this show is always having the academic and non-academic portion also. We always discuss some of the practical tips. So everyone is, madam, we all please speak in English because the show is attended by a lot of the delegates from outside the India also. So there is repeatedly requests are coming, messages are coming on the YouTube. So ma'am, please share some tips that how to expand the center in the 2 cities. Tani madam, you are muted. Madam, you are muted.
So Ritu, you want to know my secret?
Yes, your secret. Yeah. So we all will learn something.
So Ritu, it's just your passion and dedication, I must say, and support of the family, especially my husband. He's always support me, whatever I do, and definitely hard work. And you should be master in your field. That is, even Dr. Mandakini said, it should be skilled. And definitely honesty, sincerity, and dedication. And one thing more, whenever somebody is doing some mistake, your patient or your staff, you should always forgive and forget. Should keep your conscience very clear so that you can focus at your work, not anything, I mean, you messing your heart or your conscious. So you are very clear to your work. That is all. That is my work.
Thank you.
We
Thank
all.
you. Thanks.
रितु एक बात
Thank you so much, madam.
रितु
Yes,
रितु
ma'am.
एक बात बताना भूल गई. After all the
Yeah,
success,
madam. Yeah.
after all the success, whether it is Tarini, whether it is Ritu, Anita, I want to say a doctor of our stature should be very humble, very polite, and very, very warm to our colleagues and as well as to the patient. That only give a great success. A success should not get into your mind. And even after 45 years of in the active government, very high jobs, I always remember my madam's words that you should be humble, polite, and very, very warm to the people. That is one more thing which I would.
Yeah, yes, Dr. Mandakini, a good bond
Thank you.
between the doctor and patient. Very good bond of trust.
Correct. Okay.
Very true. Very true. I think this is especially very important with us gynecologists, because from one generation to another, generations are coming to us. So now, without wasting time, we are switching for the next topic, the vaccination in pregnancy. Friends, we all know, though after having the so many years of practice, still there are some confusion, some or the other is having for the vaccination in pregnancy. Earlier we are giving TT, now we are giving TDAP. Now what about the other injections also? So what are the new advancements? We all know the flu injection, earlier it was in the guidelines after 26 weeks. Now it is in the guidelines that after 14 weeks you can give any time. So now what are the other new developments? We are going to hear from none other than stalwart from the Delhi, Dr. Anita Sabarwal, madam. A warm welcome, madam. Madam, over to you.
Thank you so much, Dr. Ritu. Can I start sharing my screen?
Yes, madam. Yes, ma'am. Yes, ma'am.
Yeah, I'll just share it and then I'll get. Okay, thank you so much, Dr. Ritu, for giving me the opportunity to be part of this wonderful program which you have organized. And also very thankful for giving me the opportunity to share the same platform as of all these great gems and jewels in the field of Foxy and Obs and Gyne. Because I'm one person who's working at a very public level. I'm with the public and I'm at a public platform. I've been practicing for the last almost 39 years in Delhi, but though I'm staying in GK1, which is a very posh area, but I'm practicing in Govindpuri, which Dr. Tarni Taneja very well knows and is aware of, though her place is just adjacent to my place, but my place is called Govindpuri and her place is called CR Park. So I have really literally come across the people from, the real people who really need us most of the time. And for them only this topic today, that is why maybe you have chosen me, that I go through this topic of vaccination in pregnancy, because these are the people who from common walks of life who really require. And thank you so much for giving me the opportunity, because today is a very special day, because it's just few days ahead of a World Immunization Week, which aims to highlight the collective action needed and to promote the use of vaccines and to protect people of all ages against disease. So especially all those diseases which can be prevented and with vaccination. And also very important to talk about our, polio victory, because we just completed 12 polio-free years. And why all this happened? Because of the remarkable, work, which was consistent, and we had a lot of determination, great efforts, and genuine commitment at all levels. We, doctors, the public, the government, and everybody. So maybe if we can do that today, when we talk about vaccination in pregnancy, we can get rid of all those diseases which can happen during pregnancy. So vaccination means protection, as Dr. Mandakini said, that the woman has to be protected, the doctor has to be protected, because if you are protected, you can protect so many. So if a woman is protected, especially with vaccination, she can protect her baby, she can protect her family, and she can protect her nation and the whole world. So that's why we must give lots of importance to this protection, that is immunization. So as we all know, I must touch upon the immunity, which we have innate immunity, which our body already has, like skin. Then we have adaptive immunity, and out of which we have two, active and passive. And then out of that, we have inactive immunity. One is natural, which happens like people who got COVID, they got COVID immunity for some time. But artificial, which develops in response to vaccination. So today we are going to talk about this artificial, adaptive, active immunity, which can be imparted to our women during vaccination. So vaccination, what is vaccine? It's a biological product that can be used to safely induce a protective response or the immune response, which confers protection against infection and or disease on subsequent exposure to a pathogen. Then we have different types of vaccines. As you can see, we have the live attenuated vaccine, which is the weakened or the inactivated one. Then we have killed whole vaccine organism. And mind it, it's very important to remember that more than 200 years back, the first vaccine, smallpox, came by Edward Jenner. And we just celebrated it also. So that was live attenuated. And then this killed whole organism, typhoid. Then the toxoid, very important one, because tetanus, everybody knows, that came in 1923. And then we have subunits of recombinant proteins like pertussis, influenza, and then virus-like particles, that very important human papilloma virus, as we know, for our cervical cancer prevention. And then we have outer membrane vesicle, that is group B meningococcal, protein polysaccharide. Then Ebola is viral vector. Then SARS, this COVID nucleic acid vaccine, very important. We all are now very much familiar with this. I think every public person is also the COVID vaccine. And then now we have further two experimental ones, bacterial vectored or antigen presenting cell. Now, main difference between the live and the non-live. Live vaccine immunity parallels natural infection, though it is of slightly lower order, but non-live has generally less immunogenic activity. And immunity in live vaccine lasts for several years. Booster doses may be necessary, but in the non-live, it lasts for a very short period, and generally the booster doses need to be given. And live can be given even orally or parenterally, like we give oral polio vaccine, but non-live cannot be given orally. I think some people are speaking. Can we mute? Sarita Kapoor.
Saiti, please mute everyone.
Sarita
Saiti.
Kapoor. Yeah.
I wanted to ask you.
And what is the process mechanism?
That
It initiates an infection without.
Sarita madam, please mute
in
yourself.
2010,
Saiti.
right? And when there were apparently celebrations in the and Arundhati
Dr.
was
Sarita Kapoor, can you please mute?
Gandhians with guns, right? And also people.
Dr. Sarita Kapoor, can you mute yourself, please? Or can our organizers mute everyone?
I'm just.
Let me try.
Yeah.
I'm muting her.
Then it's gone.
I muted her. No, I muted her.
Yeah. So how it happens is that when we give vaccine, it initiates an infection without causing any injury or disease. And immunity following live vaccine administration parallels that following natural infection, though of lower order, and involves the active functioning of host immune apparatus, because that leads to the synthesis of antibodies. That is why the immunity of the person, because some people who are compromised immunity-wise, those people have, they are at a disadvantage even after giving vaccination. So sometimes we have to give them the bigger doses or the double doses. And the principle is that immunological memory, if an individual who has been actively immunized against an antigen experiences same antigen subsequently, the immune response will occur more quickly and abundantly. And there is better protection in active immunity than in passive immunity. Now we are talking about vaccination for the pregnant woman. So why are we talking? Why we need it? Major reason is that neonates do not mount efficient protective immunity to many organisms, and they're more prone to more severe or prolonged infections, especially premature babies. And secondly, it protects mother against infections that may threaten healthy reproduction, allows vaccine-induced maternal antibodies to be transferred via placenta to the fetus and in colostrum and breast milk to the infant for protection against diseases before routine childhood immunization can be initiated to the baby. And also, as we know, IgG, immunoglobulin goes through placenta, and IgA via the breast milk. Now, this is something very important, the rule of 4. Because now, as we were always just talking about tetanus toxoid, when we started doing the MBBS in 77, we were talking only about TT. And now we are talking that during pregnancy, we should give these 4, TT, Tdap, influenza, and now COVID-19. And preconception pregnancy, because just before pregnancy is also very important, MMR, varicella, hepatitis B, and HPV. Then postpartum, people who have not been able to take during pregnancy or before that, these are MMR, varicella, influenza, and HPV. And also some women who are high risk cases during pregnancy, they are to be given hepatitis B, hepatitis A, pneumococcal, meningococcal, as per the requirement, which I'll be just talking in detail. So the safe ones during pregnancy are toxoids. We all know diphtheria, tetanus, bacterial vaccine, acellular pertussis, inactivated viral vaccines like influenza and polio, which is inactivated, hepatitis A, and rabies. And fractional ones like typhoid, which is parenteral, hepatitis B, pneumococcal, meningococcal. Though yellow fever is live attenuated, but if indicated, like a woman is going to that area where it is endemic, it may be given, keeping in mind the benefits and the disadvantages. But these ones which are contraindicated during pregnancy are the live attenuated other vaccines like measles, mumps, rubella. That is why we are talking that they should be given before pregnancy. HPV, vaccinia, varicella, herpes, all these which are mentioned here, and even BCG and oral typhoid. So these are the ones which are indicated. Then preconceptional vaccination. Because vaccine preventable diseases have serious consequences for the pregnant mother, the fetus, as well as the newborn. So immunization status of women, important focal point for preconception care. So why? Because we can prevent congenital infection and perinatal transmission of all these dreaded diseases. So as we were just mentioning, measles, mumps, rubella, live attenuated vaccine, it should be avoided 1 month before or during pregnancy. Though they have observed that induced malformation, there's theoretical risk only up to 2.6%. That also theoretical risk. And increased risk of preterm labors, small just for gestational age and low birth weight babies. But if somebody has been given inadvertently or by mistake, not an indication to terminate the pregnancy. And varicella, again, live attenuated, not recommended for pregnant women. Better to give before the age of 13 years, first dose at the 12 to 15 months of age, second at 4 to 6 years. And if it's more than 13 years of age, 2 doses at 4 to 8 weeks interval. Hepatitis B, again, single dose of 20 microgram. And again, this is given intramuscular. Then we have, and it is indicated in those women who have more than one sex partner during previous 6 months or evaluated or treated for a STD, current or recent injection drug users, chronic liver disease, HIV infection, and hepatitis B surface antigen positive household contacts or sex partners. So, but if there is allergic reaction, it is a contraindication. Now, vaccines in pregnancy, TT, TD, or Tdap, as Dr. Ritu was talking of, National Immunization Schedule as per 2020, TD, that is tetanus, diphtheria, toxoid. The use of TD, rather TT, is recommended during pregnancy to protect against maternal and neonatal tetanus and diphtheria. Since 98, WHO has recommended that TT should be replaced by TD vaccine. Give TD2 or booster doses before 36 weeks of pregnancy. And even if it's mixed, that's what we were talking, that after delivery also it can be given. And even in labor, give it, and during labor also you give it. So now, as per ACOG, the recommendations are we should administer tetanus toxoid, reduced diphtheria toxoid, and acellular pertussis, that is Tdap, to all pregnant women during each pregnancy as early in the 27 to 36 weeks. Once given, no need to repeat dose at 27 to 36 weeks. But as per FOXI, 2 doses of TT 28 days apart from commencing of second trimester. Tdap vaccination can be considered instead of second dose of vaccination. But Tdap should be administered during pregnancy in order to provide optimal protection to baby during its first month of life. That is the recommendation by FOXI. And as you can see here, TT 2 doses 4 weeks apart, first dose in early pregnancy. TD 1 early in pregnancy, TD 2 4 weeks after TD 1. And booster if pregnancy occurs within 3 years of last pregnancy when both 2 TD doses were received. And Tdap is single dose 27 to 36 weeks of gestation. And then comes another important vaccine during pregnancy, influenza. Any trimester, irrespective of duration of pregnancy, which Dr. Ritu was saying, and protective value is 70 to 90%, and immunity lasts for 6 to 12 months. Provides passive immunity to the fetus also, and in suspected documented infection, immunization, along with treatment, like you are giving vaccination, but in those suspected cases, you must give oseltamivir 75 milligram twice daily for 5 days. The encounter indications, as we already discussed, and as per ACOG, the recommendations are all women who are or might be pregnant or postpartum during influenza season should receive an influenza vaccine. Any of the licensed recommended age-appropriate inactivated influenza vaccine can be given at any time during pregnancy. It has to be inactivated. And as per FOXI, this is recommended to all pregnant women from 26 weeks onwards. But in case of pandemic, the influenza vaccine can be given earlier to protect the mother at any trimester, even during first trimester. Then we talk about the high risk group, as we just mentioned. So hepatitis A, and when the woman during pregnancy has chronic liver disease or clotting factor disease, hemophilia, IV drug abuse, working near sewage or primates, and hepatitis B to household or sex partner, HPV positive, high risk behavior, chronic liver disease, HIV. And pneumococcal to heart disease or lung disease, sickle cell anemia cases, diabetes mellitus, chronic renal disease. And again, meningococcal to HIV positive, sickle cell anemia, aspleninemia, immunocompromised individuals, complement deficiency. And if they're traveling to high risk endemic areas or in contact with infected individuals, these pregnant women should be considered to be given these vaccinations. And vaccination and lactation as per the requirement, if the woman hasn't received previously or she's a high risk case, then accordingly as in the table we have mentioned, even the toxoid, tetanus, diphtheria, Tdap, or only tetanus, diphtheria, as requirement is there or as availability is there, we should be giving them. And yellow fever vaccine should be avoided in breastfeeding women. It's either better she should postpone a travel, or if she really cannot avoid, then it may be given, keeping in mind the benefits. And special situation vaccines are like, if there is epidemic or you are traveling to the endemic area, then you can give Japanese encephalitis, typhoid, or the yellow fever. So a live is contraindicated always. So it has to be the other vaccine whenever we are giving any of these cases. HPV vaccines, again, here they have mentioned these three, Gardasil and Cervarix, but now, as you all know it, now we have the Cervavac vaccine also, which has come into action. Almost in the government sector, they have put it in the schedule also. So these vaccines are very important. And now these also schedules have also changed as per WHO. Now they say that you can give 1 or 2 doses from 9 to 20 years of age. Mind it, it is now 1 or 2 doses of this vaccine are required from 9 to 20 years of age, and 1 years onward, you can give now 2 doses, which should be 6 months apart. So up to the age of 25 years. So that is there. And since Servavac is going to come, though still we haven't got it in our private market, they are selling now their 2 doses vaccine, which is costing 4,000 still. So you have to have 2 patients at one time so that you can give for 2,000 to each patient. So as per government, I think now it's for 300 or 400 rupees. Hopefully we are waiting for that to happen. So after administration of this vaccine, pregnancy should be avoided for at least 4 weeks. But again, if it has been already given by mistake and the patient is pregnant, termination is not recommended at all. And if HPV vaccine series was interrupted for pregnancy, it should be resumed postpartum. You don't have to give it soon after 6 months. And it can be given even to breastfeeding women 26 years and younger who have not been previously vaccinated. So during pregnancy, as we mentioned, hepatitis B, post-exposure prophylaxis depends on exposure. You can give hepatitis B vaccine to expose neonates. Rabies is another very important vaccine which is given post-exposure prophylaxis, and it has to be given because if you get rabies and nobody can save you, so you have to take, and I've had my own personal experiences twice. So this has to be given, and it doesn't have much side effects. So the pregnant woman has to be given if she has been bitten by a dog. Then tetanus post-exposure, again, we know varicella to expose pregnant women. This 1 dose IM within 96 hours of exposure has to be given. These are the specific immunoglobulins. And then the very, very familiar vaccine with everybody, COVID-19 vaccination in pregnancy. Since everybody knows now the whole history, global public health emergency on 30th January 2020. On 11th March, it was a pandemic, and our government of India approved COVID-19 vaccine for lactating and pregnant women on 19th May and 25th June 2021, respectively. As we all know how we were all struggling when all this was happening, and the vaccine for the pregnant women had yet not been approved. So then, what was the reason that why it should be given to pregnant? To reduce the risk of infection, as it was a public health problem, and to reduce the risk of severe acute morbidity and mortality from the infection, and to prevent long-term effects of infection, and also to prevent transmission to other individuals. So we had all different types of vaccines. I think everybody knows about it. Maybe everybody has become master in COVID because we all ourselves also took the vaccine. So Covishield and Covaxin. I took Covishield, and after that, so many came. Recommendations, WHO, I was so scared also taking the vaccine. I will get this side effect, I may not collapse there and whatnot. So all this happened with us, and we all have gone through it. WHO recommends vaccination in pregnant women as the benefits outweigh the potential risks, and FIGO considers there are no actual or theoretical risks that outweigh the potential benefits of vaccination for pregnant and breastfeeding women. Complete their 2-dose series with same vaccine product and should be administered without any other vaccine with a minimum interval of 14 days before and after administration of other vaccine. Tdap should be deferred for 14 days from administration of COVID-19. Again, RCOG also, pregnant women should be offered the vaccine with the same criteria as general population. And pregnancy testing should not be mandated before vaccine administration and not be deferred for women in pre-conceptional period. So very important, very important. So it has to be given to everyone. Then this is why it should be given, because pregnancy does not increase the risk of COVID-19. Most pregnant women will be asymptomatic or have a mild disease, but their health may deteriorate rapidly, and that might affect the fetus. So important they take all precautions to protect themselves from acquiring this, including taking vaccination against COVID-19. Therefore, pregnant women should take this vaccine. And in case a woman has been infected with COVID-19 during the current pregnancy, then she should be vaccinated soon after the delivery. So they are all available, safe, and protect women from the disease. And again, even after vaccination, all these precautions have to be taken. I think again, there is a terror which is happening. Daily we hear maybe COVID is coming back. So all these precautions will always help. And contraindications only anaphylaxis or allergic reaction or any diagnosed COVID-19 infection. So defer for 12 weeks from infection or 4 to 8 weeks from recovery. And if the active symptoms, then you don't give. And if COVID-19 is treated with monoclonal antibodies or convalescent plasma, then don't give. Acutely unwell or hospitalization patient, then also you don't give. So all guideline recommendations, vaccination in pregnancy and lactation as benefit outweighs the risk. And 2 doses of vaccine to be given with the same dose and interval as in general population. And despite of being vaccinated, take precautionary measures like social distancing, wearing mask and hand hygiene. And especially even when we talk about HPV, even after vaccination, we have to get the screening done as per the protocols. So stay safe. And if we all get together, we can really prevent all these diseases and reduce so much morbidity and mortality, especially for a woman and the children and our families and a whole country and the nation and the world. So thank you so much. These flowers I bring from my own photography of the fresh flowers, which I go to my walking place in Delhi. You are all most welcome and join me there. And there we can have our public awareness walkathon in this garden and talk about this vaccination and all your projects, Dr. Ritu. Thank you so much for giving me the opportunity. Thanks.
Thank you. Thank you. Thank you so much, Anita Madam, for such a crisp lecture. You have covered each and every point. So, yeah. Madam, our dear friend Dr. Bashir has joined all the way from Somalia. He's the Somalia Society of Gynec President. A warm welcome, Dr. Bashir. I'm not able to see you. I'm only able to read your comments. So he's also writing the lecture is very excellent. Madam, there are 2 queries I received in the YouTube. Yeah, hi, Dr. Bashir. How are you?
Thank you. Thank you. Thank you. I'm fine. Thank you. How are you?
Yeah,
You're
fine,
okay?
fine. Thank you for joining.
I'm so happy. I'm ready. I'm going to ready for the Eid after
Okay.
tomorrow. That's why I'm going my baby
Okay.
to bring some new love, you know. Thank you.
Okay. Enjoy. Yeah. Anita Madam, with your permission, can I take 2 questions? Because
Sure.
yeah, Madam, there is one question from Dr. Mona. This I received from the YouTube. She is joined from KSA, Kuwait, Saudi Arabia. Her question is, Madam, regarding this HPV vaccination. So do you think that HPV 9 is only better or HPV 4 also we can give?
Yeah, you can give any vaccine. Something is better than nothing, and HPV-4 is really good for basically a cervical cancer. So you can go ahead with that, but you must give the proper dosage and you must do the screening also. You must advise them the screening of these women after the age of 25 years. Yeah. Regular screening is a must, even if you give vaccination.
Very correct. Depends on the patient's pocket. If the patient can afford for the guard 9 strength, that is definitely a much better, more protection, more coverage. Madam, another question is from, just a second. Ma'am, this is actually these 2 questions were the same we have received. The one question is from Dr. Sheikh. He is joined from Dhaka, Bangladesh. Madam, first he has given the compliment. The same question is by our Nishant also. Which vaccine should be avoided during pregnancy? And he is saying thanks to me and to you also, Madam. Thank you for organizing such wonderful lectures, webinar, and congratulations to you, Anita Madam. He has dropped the message.
Thank you so much, sir. And as I mentioned in my slides, all the live attenuated vaccines they are contraindicated during pregnancy. I just mentioned about that yellow fever vaccine because if that's so important, the person has to visit that area which is endemic with yellow fever, and then keeping in mind the benefits and the potential risks. So if they outweigh, then we can give yellow fever. Otherwise, all the live attenuated vaccines are contraindicated during pregnancy. That's why we recommend that give them before pregnancy, and that too 1 month before the woman conceives. So that minimum gap of 4 to 5 weeks should be there.
Yeah. Thank you, madam. Madam, there is one also very important question because this is such a burning topic. A lot of doctors want to ask. There is one question from Dr. Madhu Dada. Yeah, thank you, Dr. Madhu, for joining. She's writing, what is the right time for the first dose of injection TT?
See, ideally 16 weeks, but in a government sector, they say if the woman comes even in the first trimester, because she's lost, she never comes back again. So they say whenever the woman comes during pregnancy, they give it. But ideally, it's always good if we give it during the early part of second trimester.
Her another query, ma'am, in the chat box only. Should this vaccine is to be avoided in the first trimester?
Which vaccine should be avoided?
Regarding TT only.
Yeah. This is what I said, that ideally we give 16 weeks, but even if you give during first trimester, it will not cause much harm, not harm at all. Because in a government sector, they are giving it even in the first trimester. Because keeping in mind that women may not turn up again ever. So if she's come, at least give her some vaccine. That is the main aim. So you can give it. See, we also said that some vaccines, even if you give, we don't advise to terminate the pregnancy. Even if you give HPV and you think, oh, you have given during first trimester, now you should terminate. Even that is not advisable. Even if there is any risk, that is very little, and that also is theoretical risk. So you may give, but it is better if you have proper, like if see, I am in Govindpuri, but my patients come from all walks, but if I counsel them, they all come back to me, and I have never given during first trimester. Always I gave during the early part of my second trimester. So if you counsel them, patients understand and they come back.
Thank you, madam. Because these days patients are also coming after Googling everything. So we have to explain everything very properly. Madam, there is one question from my dear friend, Dr. Poonam Gupta. Poonam is always joining our webinar. She is from Varanasi. Dr. Poonam's question is, Tdap should be given at which time? I think madam has everything is covered. Poonam, Dr. Poonam, I think you have joined late. Yeah. So, yeah. Mandakini madam, there are a lot of compliments are coming for you also. Yeah. Thank you.
And
Thank you so much.
But there are no questions for me because they know the answer.
Till now we have not received any question. So now, friends, now we are moving for the third talk, a much awaited talk, which is none other by our dear friend Dr. Shushila Gupta madam is going to take a very, very important topic regarding the thyroid and infertility. So we seeing the patients of the thyroid disorder every day in our OPD. So a lot of confusion each and everyone is having regarding the thyroid management also. I think I will invite once again Dr. Komal also. Dr. Komal, are you there? Dr. Komal, are you there?
Yes, I'm very
Dr.
much here.
Komal, yeah. Dr. Komal has done lot of work in this medical disorders of pregnancy. Dr. Komal, before you leave, I want that some take-home messages for the practical points you share here. Then we will start the Shushila madam's talk.
Yes. So I think both the talks were fantastic. I was just about to compliment Dr. Mandakini Meg and Dr. Anita Sabharwal. So many issues keep coming about vaccination. That is the main thing. And the practical point now in vaccination, particularly, I would like to highlight that there is a lot of dilemmas whether, it's a prenatal vaccination. Like we counsel patients to take vaccine prenatally, and sometimes they get pregnant, immediately. So the counseling becomes a bigger aspect where we need to counsel them. We need to tell them that if they have taken 28, 4 weeks away, 28 days or 4 weeks away, then there is nothing to worry. But that is within that duration, then the patient requires a thorough counseling. Also, the HPV vaccine, which we are now giving to everybody, and we are seeing the incidence of cervical cancer actually coming down. But what is the thing is that we start as a prenatal, and sometimes patient gets pregnant. So that HPV vaccine should be encouraged for the pregnant patient to take in the postpartum period. So I think postpartum also is a very good period for sensitizing and talking and counseling patient for vaccination. And I think we should not let it go, because the patient thinks about herself, and we should talk about all the vaccine. If she has not taken, to complete the dosage or to initiate a vaccine. Those vaccine like HPV and all are safe in postpartum period. So we can actually tell them, encourage them to take it. So this is a very good thing. And lastly, about the cocooning of the all guidelines, that is basically all the proxy are telling that you take the vaccine, that is TD, and all these vaccines should be taken in the later part, that is after 26 to 32 weeks, because they give the effect to the family members also. There is a cocooning phenomenon, which all the pediatrician and all, they work on it. And there is also a concept wherein most of the families, they're counseled, and all the caregivers also take vaccines, so that the neonatal pertussis and everything is prevented. So all these concepts keep coming. There are a lot of dilemmas, but definitely, yes, the second dose, yes, you take after 4 weeks. I think Dr. Anita has rightly said that there should be a gap. Sometimes some people are giving the first TT, but second they give TD. So that is also okay. They can do in combination. But I think now TD has taken over everywhere, and we are giving TD also. And if patient has taken a TD, it needs to be repeated in every pregnancy, the one dose. It's not that they get pregnant frequent. And sometimes there is a dilemma that whether to repeat in the next pregnancy. Yes, they need to repeat it if they become pregnant also within the next year. So these are all the practical points which I wanted to highlight. And Dr. Mandakini Meg actually has said so well about the cesarean section. And there is nothing much to talk about it. It was a very elaborate talk, actually. Highlighting all the points, even the tocophobia, everything. The how to monitor the patient, what should be the parameters, how much trial should be given. So I think a very educative and very enriching webinar it is happening, and I'm eagerly waiting for the hypothyroidism talk. But I have to talk to my doctor also. So I was just thinking maybe I'll miss it because it was getting late. So let's see how much I can attend this talk. Also, I'm waiting for Dr. Sushila's talk.
Thank you. Thank you. Thank you, Dr. Komal, for your comments. So friends, I think this is now clear that HPV vaccination, we have to promote postpartum also. In my routine practice, the girls who are coming to me for the infertility treatment, I usually advise them. Usually they take the one dose, and in between, if they are getting pregnant, then post delivery we are completing the other 2 doses. So if she has taken 1 dose prior also, that is not going to be wasted. So now I am stopping here and starting the much awaited talk of the today, the hypothyroidism in infertility and pregnancy. Over to you, Shushila madam.
Thank you very much, Dr. Rita, for giving me this opportunity, and I welcome my chief guest and guest of honor, Dr. Komal and Dr. Mandakini, and all my colleagues and audience which are there present there. And without wasting much time, I'll just go straight to the topic. What is hypothyroidism in infertility, especially in fertility? Because what is hypothyroid? When the thyroid gland is not able to make proper thyroid hormone in the circulation, that is hypothyroid. But before going to the main topic, I'll discuss few conditions like subclinical hypothyroid and artificially immune hypothyroidism, so that we can be very clear cut what is subclinical and what is the scenario in different stage of the hypothyroidism. Subclinical hypothyroidism is also called mild thyroid failure. It's diagnosed when peripheral thyroid hormone levels are within normal reference as the laboratory ranges, but the TSH level, thyroid stimulating hormone level, are mildly elevated. And this condition is almost 3 to 8% in our general population. And second condition is autoimmune thyroid disease. Autoimmune thyroid disease is caused by the disorder of the thyroid-related autoimmune system, characterized by lymphocytes infiltration and the appearance of thyroid antibodies. And thyroid antibodies are anti-thyroid antibodies, mainly includes thyroid peroxidase antibodies, and mainly we are getting tested only for TPO antibodies most of the time. And rest of the antibodies we are not commonly testing, but they are thyroglobulin antibodies and thyroid stimulating hormone receptor antibody. thyroid autoimmune disease is 5 to 10-fold higher among the women than men, probably because of the combination of the genetic factor, estrogen-related effect, and chromosome X abnormalities. And TAI is most common autoimmune disorder affecting 5 to 20% of the women in childbearing period. And this is the main cause of the thyroid dysfunction. And this thyroid autoimmune disease can be present without thyroid dysfunction or maybe with thyroid dysfunction. Ultimately, autoimmune thyroid disease, if it is progressive, may lead to hypothyroidism. And if we see in the infertility, 1 in 8 women in their reproductive age, they have any of the thyroid disorder, and about 20% of infertile women are found to have hypothyroidism. And the prevalence of hypothyroidism, overt and subclinical, among infertile women, this is very, very different in different area, is 1 to 43%. So women with infertile should have screened with TSH as part of their infertility workup. As we investigating for other factors of the infertility, thyroid screening should be mandatory in all the infertile couple. And how do we screen these infertile couple? The algorithm for screening of thyroid is TSH and TPO antibodies. If TSH is raised, then levothyroxine treatment has to be given. If it is in a normal range, then TPO antibody has to be done. And if TPO antibodies are positive, then that patient has to be followed properly during infertility treatment and during antenatal phase, whether they are developing hypothyroidism or not. We will discuss in few slides what happens with the hypothyroidism or artificially immune disease when they try to conceive and when we are giving hyperstimulation of the ovary. The most common diagnostic test, what we do in our protocol, thyroid stimulating hormone T3, free T3, T4, free T4, and TPO antibodies. The test TSH values are normal is 0.5 to 4.7 milliunit per liter, T3 0.9 to 0.92 to 2.78 nanomole per liter, free T3 is 0.22 to 6.78 picomole per liter, T4 is 58 to 140 nanomole per liter, and free T4 is 10.3 to 35 picomole per liter. And now coming to the hypothyroidism, how it causes infertility. Hypothyroidism causes infertility because of the ovulatory disturbance, and this ovulatory disturbance can be direct or indirect effect, like hypothalamo-pituitary changes and impair the LH response to the GnRH stimuli, and high TRH causes hyperprolactinemia, and increased TSH also causes pseudo feedback inhibition of FSH-LH, and it may be because of the decreased SHBG pool and causing less androgen clearance. So these all factors causes ovarian volume, increase in ovarian volume and stroma deposits, leads to ovarian disturbances. The role of thyroid hormone starting in the reproductive age, in the menstruation, in the pregnancy, and during infertility workup. So menstrual pattern is also influenced by the thyroid hormone directly through impact on ovaries or indirectly through SHBG, prolactin, and gonadotropin releasing hormone secretions. And the best part is when we treat thyroid dysfunction, it can reverse to the menstrual abnormality and thus improve the fertility also. In infertile women, the prevalence of autoimmune thyroid disease is significantly higher compared to the Paris women. And this is especially in case when the patient is having with endometriosis and PCO. Whenever patient is having ovulatory dysfunction, the thyroid autoimmune disease are more prevalent. And AITD does not interfere with normal fetal implantation and comparable pregnancy rate. But if these patients conceives and during first trimester, however, pregnant women with AITD carrying significant increased risk of miscarriages compared to the women without AITD. And it has also been demonstrated that controlled ovarian high stimulation in preparation of ART has a significant impact on thyroid functions, particularly in women who are having artificial immune disease of thyroid. So it is therefore advisable to measure thyroid function and detect AITD in infertile women before ART and to follow these parameters after controlled ovarian hyperstimulation during pregnancy in infertile patients. What happens when we stimulate patients in ART? The ovarian hyperstimulation is used to obtain multiple cumulus oocytes complexes, and the estradiol concentration is much higher than the without stimulation. So marked rise in estrogen concentration induces an additional strain on the hypothalamic pituitary thyroid axis and could therefore considerably impair thyroid hormone distribution, kinetic, and especially in women who are having TAI. Other indirect effect may also be there because of the hyperprolactinemia due to increased thyrotropin releasing hormone produce and altered pulsatile secretion of gonadotropin releasing hormone, leading to the delay in LH secretion, LH response, and inadequate formation of corpus luteum. And direct effect can also be there because of the modulation of the T3 of the action of follicular stimulating hormone and luteinizing hormone on steroid biosynthesis. And the majority of the circulating, what happened in the pregnancy? In pregnant women with a low iodine intake or history of TAI, the required increased thyroid hormone production cannot be adequately met, and they develop hypothyroidism because during pregnancy, level of thyroxine binding globulin gets double, and which markedly increase the number of T4 binding sites. And it is known that thyroxine binding globulin has the highest affinity contrast to the T4 and the tyrotyrosine. As we know that majority of the circulating endogenous T3, T4 is transported by the thyroxine binding globulin, transthyretin, and the albumin. And this is again the repetition, but this is the published data in the Clean Endocrine Postgrad. Like Kress et al. Showed that prevalence of oligomenorrhea was 23% among hypothyroid women compared to with the 8% among euthyroid control. And this menstrual irregularity is also associated with the TSH level also. More the TSH level, elevation of the serum, more the menstrual irregularity is there. Hypothyroidism is also associated with the menorrhagia because of the altered production of the coagulation factors such as decreased level of factors 7, 8, 9, and 10. The prevalence of hypothyroidism in women in reproductive age varies from 2 to 4%. And the thyroid hormone receptor have been described in human oocytes when they synergizes with the luteinizing hormone, human chorionic gonadotropin receptors, and follicular stimulating hormone. So they exert the direct stimulatory effect on granulosa cell and trophoblastic differentiation. And this is again the published article in Endocrine Metabile. Kramer et al. Showed that serum TSH level was significant predictor in IVF failure when TSH concentration is significantly increased in women produce oocyte that failed to achieve fertilization. So the concept of subclinical hypothyroidism has been challenged, and so much so that some authors have also proposed restricting the upper limit of TSH 2.5 like we are taking in pregnancy. This is endocrinology MedPep into published in Endocrinology MedPep. This is again the association with the infertility. To determine a correct prevalence of subclinical hypothyroidism is not easy, because when we are working up or before infertility, hypothyroid patients already they are being treated, and the prevalence of subclinical hypothyroid in fertile women is highly variable as it is in general population and depend on the geographical area also. When thyroid dysfunction is detected, when we have detected the thyroid dysfunction is there, the treatment of levothyroxine treatment should be given. Although AITT per se does not compromise pregnancy success rate, women with AITT carry an increased risk of miscarriages. So the controlled ovarian hyperstimulation lead to an additional strain on thyroid, especially in the women with AITT. And this again further, there is a further strain in the pregnancy also. So whenever patient is of artificially immune disease thyroid, we have to follow these patients because there is a strain on thyroid gland or in the ART technique when we are doing a hyperstimulation and further in the pregnancy also. When we want to, patients want to conceive and we are treating hypothyroid, but patient is not hypothyroid, but only having autoimmune disease of thyroid. And it has been reported that per se, implantation failure is not there, but the chances of miscarriage is there. And our motto of treatment of infertility is not to just to have conception, but to have a healthy baby. So we have to see in the pregnancy also. There is a correlation between thyroid antibody and miscarriages in cohort studies. It has been seen, and there is a correlation in the miscarriage in further net clean packed endocrine multiple studies done in 2008. So the association between thyroid disorder and miscarriages and between hypothyroidism and risk of decreased psychodevelopment index in progeny suggests that screening should be beneficial. And before systemic screening, the application of tests to detect subclinical disease is stratified. But before investigation, there must be some prerequisites must be fulfilled before getting to investigate them. And in pregnancy, what protocol we follow in high-risk women or when TPO antibodies is there, we investigate patients for TSH. If upper limit of TSH is 0.1 to 2.5, then no further treatment is required. If TSH level is 2.5 to 10, then TPO antibody should be done. And if TPO antibody is negative and upper limit is 2.5, we can leave these patients. But if upper limit is more than that or nearing 10, the treatment should be given in the TPO positive patients. If upper limit is 2.5 and TPO antibodies are there, we have to follow or we can give some treatment also in these patients. And according to the guideline in India, we just follow in first trimester, TSH should be 2.5, upper limit of TSH 2.5 milliunit per liter, and in second trimester 3 milliunit per liter, and in third trimester also 3 milliunit per liter. It has been seen that thyroid auto and antibodies and miscarriages in different studies has been published in BMJ also. And there is a correlation with the preterm birth also, and this is also a study published in BMJ. So in 2017, the guidelines of American Thyroid Association that the diagnosis and management of thyroid disease, not only in infertility, but during pregnancy and postpartum has to be investigated and treated. And it has been seen that when the treatment is given with levothyroxine, definitely the results are much better. So the treatment should be given with the hypothyroid, and clinical thyroid dysfunction has been associated with pregnancy complicated such as hypertension, preterm birth, low birth weight, placental abruption. Pregnancy in women with subclinical hypothyroid are 3 times more likely to be complicated with placental abruption. And preterm birth, also defined as delivery at before 34 weeks of gestation, was 2-fold higher in women with subclinical hypothyroidism. And this is a review article published in Obstetrical Gynecology 2005. And it has been, if we investigate patient of hypothyroid before 20 weeks of gestation and treating those patients, then the chances of hypertension, gestational severe eclampsia, placental abruption, and gestational delivery, they all side effects, these all complications are much less in the treated patients. And not only the maternal outcome, but fetal outcome was also better in treated patients when they investigated before 20 weeks of gestation, like necrotizing enterocolitis, respiratory distress syndrome, umbilical artery, blood pH, Epworth score, and admission to intensive care unit. So the levothyroxine possibly reduction in the preterm birth and miscarriages has been published in Cochrane database systemic review in 2010, and selenium-methnion was also having very positive results when patient is not having hypothyroid but only thyroid autoantibody is present. And it has been seen that if we treat the patients with selenium-methnion, also AITD patients, the chances of preeclampsia, preterm birth, miscarriages, hypertension, they are much less. In the maternal and fetal also they are less. So the thyroid dysfunction and thyroid autoantibody are prevalent among women reproductive age as are associated with adverse pregnancy outcome. So pregnant women with subclinical hypothyroidism or thyroid antibodies has increased risk of complication like preeclampsia, perinatal mortality, morbidity, and miscarriages. So there is a subclinical thyroid dysfunction and thyroid autoimmunity before conception in early pregnancy, And this is the systemic view published in Human Reproductive Update 2011. So at the end, the patients with subclinical hypothyroidism are facing an increased risk of eclampsia and multiple and perinatal mortality and multiple complications in pregnancy. So presence of thyroid antibody in euthyroid patients is associated with unexplained subfertility. The chances of miscarriages and recurrent miscarriages and preterm, they all are more. And special attention in pregnant women at risk of diagnosis with abnormality in the non-pregnant patient with history of recurrent miscarriage is desirable. So the therapeutic option and thereby the variability of a standardized screening program remain to be established in near future. This is, it has been also seen that IQ level and cognitive performance of children born to levothyroxine 4 treated hypothyroid mother is similar in those women have maternal subclinical hypothyroidism during pregnancy compared with those whose mothers have normal TSH concentration during pregnancy. So the hypothyroid is usually treated with the thyroxine doses of the according to the patient weight and TSH level. And the key points of take-home messages are hypothyroidism is due mainly to chronic autoimmune thyroiditis and associated with increased morbidity during pregnancy. Hypothyroidism is associated with infertility, seems to be increased only in women with ovulatory dysfunction, whereas the frequency of thyroid autoimmunity is raised in infertile women as endometriosis and PCO patients. In spontaneous and medically assisted pregnancy, the presence of thyroid autoimmunity is associated with significant raise of frequency of miscarriages, even when thyroid functions appear to be normal. Screening for thyroid dysfunction, autoimmunity, or both should be performed as a part of workup in women with infertility and other well-defined high-risk conditions. Levothyroxine therapy should be administered for subclinical and overt hypothyroidism, especially if menses are irregular. Assisted reproductive techniques or controlled ovarian high stimulation have been used during pregnancy. And thyroid hormone play an important part in normal reproductive function, both through the direct effect on ovaries or indirect effect. And thyroid function can lead to menstrual irregularity and infertility. Women with infertility should be screened for thyroid dysfunction, especially when endometriosis or ovarian dysfunction. And when thyroid dysfunction is detected, thyroxine treatment should be given, and it has reduced the menstrual irregularity and requirement of ART technique also. Thyroid autoimmune features without apparent thyroid dysfunction do not compromise conception, but women with chronic autoimmune thyroiditis carry an increased risk of early miscarriages. Then hypothyroidism during pregnancy should be avoided, and it is associated with increased morbidity and poorer outcome of pregnancy, both in morbidity and the progeny. Further research is needed to answer crucial issues concerning whether systemic screening should be performed before and during pregnancy. Thank you very much.
Thank you.
Thank you, Shishila Madam, for such a brilliant lecture. Madam, there are a lot of questions we have received. The first question is by dear friend, Dr. Bashir. Yeah, Dr. Shivani is also joined. Welcome, dear Shivani, the surrogacy queen of India. I missed the question. Nishan, can you help me in the question? Nishan, 1 minute. I think the yeah.
Yes.
Sushila Madam, there is one question from Dr. Bashir.
May I give a introduction, same time treatment in hypothyroidism?
Yes, of course. I think he's want to ask something else. No?
Yes, I can see one question. What treatment do you give for women with antibody level 300 who is pregnant, diagnosed during pregnancy? This is anti-thyroid antibody level, or we are talking about TSH level?
Dr. Shivani Gaur has his question. Shivani Gaur ma'am, you can please elaborate your question.
What's the question? Actually, I'm not able to open the chat box.
I can, whatever I've read, is actually we are treating hypothyroid on the level of the TSH. Basically, we maintain the level of TSH.
No, Sushila ma'am, what I was asking was that I have a patient admitted and she was admitted because of subchorionic large hematoma, risk of miscarriage, and incidentally somebody ordered thyroid antibodies for her and they have come out to be 350. So should I give any treatment or just monitor, just give bed rest and progesterone for the threatened miscarriage?
Basically, that treatment has to be given, progesterone and whatever we are giving for threatened miscarriage. But we are treating hypothyroid on the basis of the TSH level. If these antibodies, only antibodies are there and upper limit of TSH is 2.5, less than 2.5, then we can wait. Or we can do serial testing of TSH, or we can start treatment also. Sometime if TSH level are normal and patient is high risk patient, then sometimes very small dose we can start. But at the same time, we are maintaining the TSH level 2.5 and just vigilant and watch on the TPO antibodies.
So that is what I wanted to know. No steroids or anything to be given just because she has antibodies positive, nothing to be given.
Because मैं बहुत सारे patients को I am sending to the endocrinologist also. They also do not suggest. Abhi last month में 3-4 patients I have sent to the Dr. Ajay Agarwal, and he also, I discussed with him. He said ki serial, and he also gives importance to free T3 and T4 level also. If thyroid hormone or definitely less, then we have to.
Yes, ma'am, we are doing the same thing, that I have not started any treatment for the TPO antibodies, but I decided that every month we'll just keep checking free T3, free T4 and TSH.
What about TSH? What about TSH and T3, T4 level in this patient?
Keeping it less than 2.5.
Keeping less than 2.5. Then we can be vigilant also.
ठीक है, ma'am. Okay, thank you, ma'am.
Thank you. There is one more question. This is, I'm taking the last question. That is from Dr. Bashi.
May I give ovulation induction same time treatment in hypothyroid?
That we can do. I think
yes,
one more.
Yes, we can do. And whenever we are doing induction ovulation, then definitely we have to keep TSH level little on a lower side.
Thank you.
Less than 2.5, like we are keeping in pregnancy.
Yeah.
And TPO antibody should be done.
Thank you, Professor. I have a next question. I have a case. She have secondary infertility for 4 years since. And during investigation, I guess she have a hypothyroidism. At the same time, she have high hyperprolactinemia. And may I treat both of them during treatment, or how is the relationship between hypothyroidism and hyperprolactinemia? Thank you.
We should start treating hyperprolactinemia and hyperthyroidism, and after correcting hyperprolactinemia, only then we can start ovulation induction.
Thank you.
Dr. Sushila?
11 o'clock.
Dr. Sushila?
Yes.
I have a patient post-thyroidectomy, and she wants an IVF procedure. She is maintained on 100 micrograms of altoxin. So what you advise?
She can continue pregnancy after thyroidectomy. This is very, very common. Hypothyroidism is very common, and we have to treat and maintain the thyroid hormone level.
Well, she is post-thyroidectomy. Now she wants the IVF procedure.
Yes, we can do by maintaining her thyroid level, TSH level and thyroid hormone level in maintained position. Yes, we can start.
Any change in the ovulation induction? Nothing. We have just to monitor the TSH
Just
level.
monitor, because we have to monitor carefully because of like high estrogen level. When we are hyperstimulating, there are lots of we are making lots of follicle, and estrogen level are very high. Then because already thyroidectomy has been done and she requires more of thyroid hormone. So dose may be requirement of the dose may be little more.
Yeah,
Thank
very
you.
true, very true.
Thank you. Very
As,
true. Thank you.
Yeah, as Sushila madam has also mentioned, of course, never hesitate to take an opinion of our other colleague also. Yes, of course, in this era, I think always we take a one opinion from the endocrinologist too. So I'm able to see Dr. Fadumo and Dr. Waris Muhammad. You have joined from which place? Do you want to ask some question? Because I am seeing that one has raised the hand. Dr. Waris and Dr. Fadumo. So I think, yeah. So there are no more questions and it is already 11. Yeah. So thank you. Thank you, friend. My webinars usually go by this time. So thank you, dear friends, and thank you all the stalwarts. A special thanks to Tarani madam, Dr. Komal Chauhan, Dr. Shushila, Dr. Anita madam, Dr. Mandakini madam. Thank you for joining, and thank you Shivani too for joining, and my dear friends, of course, my academic family, my academic buddies. Without this, no webinar can be successful. Dr. Yajini madam has joined from all the way from Madurai. Dr. Rupali, Dr. Kamlesh Mishra, they all are my academic buddies. Dr. Madhu, Dr. Uma Devi from Tirupati. So many friends have joined. Dr. Geeta, Dr. Reza. Yeah, good to see you all. Friends, keep on the spirit. Let's keep on discussing the academic things.
Thank you.
And of course, our dear friend, Dr. Bashir. Good to see you, Dr. Bashir.
Good to see you. Thank you, all of you.
Yeah.
Congratulations.
Congratulations.
Thank you.
Thank you,
Many
madam.
congratulations, Ritu. Such an educative program. That's why it's so globally popular. Keep it up.
Yeah.
You are really doing wonderful
Happy
work.
Eid, Dr. Bashir. Enjoy your Eid.
Thank you, Shivani. Thank you.
Bye.
Yeah.
Hopefully we will
thank
meet
you.
soon, Dr. Bashir. Hopefully we will meet soon.
Inshallah. Thank you.
Yeah.
Soon,
Okay. Bye. Bye.
It's on
Bye.
22nd, Dr. Bashir. It's
Thank
coming.
you.
It
Take
is
care.
coming.
And
It is
thank
coming.
you.
Yeah.
So in
Happy
advance, happy Eid.
Yeah.
Okay. Thank you.
Yeah. Thank you, Dr. Kamlesh. Thank you for joining. Yeah. So we are winding up now today. So in
Bye,
advance,
everyone.
happy
Good night.
Akshay Tritiya. On 22nd, we are having Akshay Tritiya, main festival, and Eid also. So wishes for both of these. Yeah. And friends, next week we are connecting on Thursday. In this week, we are having Dr. Kamrun Nahar all the way from Bangladesh with us. I will share the topic tomorrow. Yeah. Bye-bye. Good night. Thank you.
Bye.
Thank you, everyone.
Ritu, before we depart, I must congratulate because we are staying till end. It itself shows the academic content and very interesting topic. We want to listen to those topics. And so I think you are doing a great job. Keep it up and keep the spirit of academics very high. Thank you very much.
Thank you.